All right, Mayor, go ahead.
Thank you, Steve. Well, welcome to the 19th edition of our special virtual Mayor's Breakfast. We've been doing for the last 6 months now. It's hard to believe, but we've been doing this for 6 months. Today's program is two of our guests who've consistently been here almost every week or every other week for us. And that's our Supervisor, Candace Andersen, and Dr. Joseph, who are going to be addressing and be our main speakers today to go in depth on the county restrictions and the new health requirements coming up and how that criteria is going to work. And then Dr. Joseph, again, will talk about COVID and giving us good information about what's going on, progress. I loved his comment to me earlier at one time where he says there's lots and lots of noise, but not a lot of music right now in terms of how it's all. I thought that was rather interesting. But I'm going to start off and introduce our Deputy City Manager, Steve Spedowfski. And Steve, an update on the city to start the day.
Great, thank you, Mayor. So as everybody has probably heard, and hopefully you're following the city on all of our channels, subscribing via email, Twitter, and Facebook, that we have moved into the red category with the county. And in about an hour at 10 o'clock this morning, our playgrounds will reopen. And I just wanted to highlight that this morning and make sure, and bear with me here, I'm gonna go as quickly as I can through the guidelines because it is not just an all-out opening, free-for-all. There are some restrictions. And I know this has been of interest to San Ramon residents in particular lately with all of our parks and facilities. They've been wanting to get back on the playground structure. So we will have signs posted at every playground reminding people of the rules, and they are the following. Face masks over the mouth and nose were required for everyone 2 years of age or older with caregiver supervision at all times to ensure face mask use. Do not use the playground when different households are unable to maintain a physical distance of 6 feet. Maintain a physical distance of 6 feet between children and adults from different households, including children using or waiting to use the play structures. Parents and caregivers must monitor and keep adults and children from different households at least 6 feet apart. Elderly persons with underlying medical conditions should avoid playground when others are present, probably in particular the slides. Consider coming on different times or days to avoid wait times and potential crowded times. Wash or sanitize hands before and after use of the playground. And the playgrounds will be cleaned and sanitized by the city of San Ramon 3 to 5 times per week by our public works staff. What will not be opening, we've been receiving questions on this as well, are the splash pads. Those will remain closed. It's very difficult to keep social distancing and also, the water involved with the splash pad for those. And also, I'd like to remind residents that we still have lap swimming available at our pools because we've been getting questions about pools again. So again, this isn't a full opening, again, a free-for-all for the parks, but we are abiding by the health order regulations, and we're happy to see them open up today in about an hour in some capacity.
And as a follow-up question, Steve, we do joint parks with our schools here in San Ramon, and they have playgrounds. Are those playgrounds going to be sanitized by the city, or is that a city or a school responsibility? Are they also open?
So we are the responsible party for the maintenance, so I believe we will be the ones doing the sanitizing as well.
And the same rules apply to school ground playgrounds?
Same rules apply. We just, received word about playgrounds reopening, I believe it was this week, and we've been working as quickly as we can to get the proper signage and get all the rules in place for the playgrounds to open.
Great information. Thank you, Steve. And later on, Steve will be asking questions of our guests. And if you have any questions, send them to info@sanramon.ca.gov. And now it's my pleasure to introduce Candace Andersen, who's been here on all 19 of our broadcasts, giving us an update. A lot's going on. There's a lot of information. So we actually expanded the time for Candace this morning to go into sort of what's going on and what to expect over the next 2 to 3 weeks and the nuances that are involved in that change that's going on. So Candace, thank you for being here again.
My pleasure. It's always fun to be here with you, Bill. And so let's talk about where we are now. And so as Steve mentioned, as I know everyone was really anxiously awaiting, we did move into the red tier. And just to remind you, there is a state tier system. Purple is the highest, where it's most considered widespread. And that's where we started out. And that meant that we had more than 7 cases per 100,000 people on average per day, and that we had a positivity rate of more than 8%. Luckily, our positivity rate was consistently well below that. It met the red tier standard, but we were hovering right around that 6 to 7%, a little bit over cases per 100,000. We, for 2 weeks in a row, beat that. So to move down to the next tier, the less restrictive tier, you need to be in the new tier for 3 weeks. So guaranteed we will stay in the red tier for a minimum of 3 weeks. And then if we want to move down to the orange tier, we will need to meet the orange tier's standards for 2 weeks. And so in comparison, in the red tier, we are supposed to have 4 to 7 cases per 100,000 people per day. And our positivity rate should be somewhere between 5 and 8% in the red tier. To go into the orange tier, we need to drop down to 1 to 3.9 cases per 100,000 and 2 to 4.9% of positive cases. And so right now we are not quite even meeting the orange tier's requirements. We are currently at about 6.3% of cases, 6.3 cases per 100,000. Our positivity, though, is right now about the 3.7% positivity. So once again, positivity looks okay, but our cases are not quite there at this time. Now, the new wrinkle in all of this is that the governor announced this week that there is going to be a social equity provision that is also added, and it's going to take effect next week as you start looking at moving from tiers. And essentially what it's saying is we also need to look at, in a county such as ours, our disadvantaged communities. And this is the lowest quartile of our health index. We're supposed to be getting a graph out hopefully today on our own website of what those communities are, but they also need to meet the positive percent case standards. Because while on average we are doing well, we've got a countywide 3.7% case, positive cases, we are in some of our more disadvantaged communities, Richmond, San Pablo, Bay Point, parts of the Monument Corridor, we're hovering closer to 7% in those areas. And so what the state is saying, you've got to bring down those areas too. Now, they're not saying you have to bring it all the way down to be the exact same average, but in our case, it would need to be down to about 5.2% case positives before we could start qualifying to go into the orange level. And so that's something that has been challenging for especially large urban counties such as ours, where you've got 19 different cities, you've got a lot of social justice issues, a lot of health inequity issues that have been going on for a very, very long time. And it is challenging in the middle of a pandemic to try to address those as well. But it's something we have been working on for a very long time in this pandemic. We started seeing within 3 months into the pandemic that the cases were very much higher in these communities. And a large part is because these individuals don't have the luxury to work from home. Many of them have been frontline workers. They come out and they work in our communities. They work throughout the county. Many of these individuals live in families where they have multiple families in the same residence. There has been some language barriers. And so from day one, I was even filming some, Spanish, not that my Spanish is that great, but some ads in Spanish, doing more outreach. And so we've really come up with a much, much more comprehensive approach to this. And in fact, the state, starting October 6th, wants each county to outline exactly what their plan is to address these communities. And so what we're also doing is some of the things that we've already started doing is we've been doing more testing. We set up, last 2 months, we've been setting up additional testing, more just walk-in testing where you don't have the barriers of trying to make an appointment. We've been working with our health partners in those communities. Beyond our regular healthcare providers, we've got places like La Clinica. We have some other other healthcare providers that treat individuals regardless of their citizenship. We have been working with combining testing with flu shots, doing more outreach through what we call our ambassadors, which in often case are youth, others who are more in tune with individuals in there. We're working with what we call our trusted partners. And these are people that individuals in a community trust. It might be a pastor at a church. It might be a community organizer that they regularly work with. It's someone that they trust for information. We are doing a Bay Area wide, all of the health officers through their public information officers, more outreach in different languages. We're making sure that people realize that if they in fact become positive for COVID, they in fact have a place where they can quarantine. We do have, excuse me, hotel beds that are still available, not just for our homeless population that we've been housing, but it also is for those individuals who don't have room in their home to self-isolate if in fact they test positive. We're also working, and when I say enforcement, because as you all know, we did go ahead and pass an enforcement, administrative enforcement ordinance a couple of months ago, but really working on those areas where we're seeing extreme violations. For example, if a bar is open and it's encouraging people to gather. I'm not talking about going down the street and doing face mask violations, but in fact, in those communities where we're seeing people congregate and potentially spreading the virus, we're working with that as well. And so those are, really important things. I think one thing I'm really trying to be very cautious of is not putting it in the lens of it's them versus us, because that is not the case. We track our COVID cases based upon where someone resides, not where they work. And so many of the individuals who are coming down with COVID may very well be contracting in our own communities as opposed to in their own. And so we're trying very hard to avoid some stigmatization of those cities, those communities where there's a higher amount, because it's spreading within all of our communities. And we all need to continue to take the measures, the very important measures that we need to take. Now let's go on to the good news, because we did enter into the red tier. And as I was hearing this whole equity new layer that was going to go on to moving into tiers, I was very, very concerned that we would not get into red first, because getting into red opens up a lot of opportunities. And we can stay in red and live very comfortably as long as we continue to do the important things of wearing a mask when you're out around other people in close contact, washing your hands frequently, not going out when you're not feeling well, continuing to take these very important precautions anyway. So the fact that we're in the red tier, and I will add one more thing about the equity provision, the equity provision will not cause us to go back to another tier. So we're in red. If we don't meet these equity numbers, it won't move us back into purple. It will, though, slow us down potentially for moving into the orange category. So with red, retail businesses are now able to open up to 50% maximum occupancy rather than 25%. So those of you who are waiting in line sometime at your favorite grocery store or your favorite boutique, that's going to lessen that up. We were very excited to see restaurants and museums can operate indoors at 25% occupancy. And that's great. We've got some wonderful smaller museums, both in San Ramon and Danville, historic museums that now can be open to visitors on that scale. And of course, the beautiful Blackhawk Museum up in Blackhawk, which has great capacity. They're now able to open up at 25% capacity as well. Places of worship, movie theaters can now open at 25% capacity, and or up to 100 people, whichever is the lower amount. Again, this opens up more opportunities. Indoor gyms, 10% occupancy. And I know our gyms have been really preparing for this. It doesn't sound like a great amount. We'd love to be at 40 or 50 or ultimately 100%, but 10% is a great start. All personal care services now, including massage, can move indoors. Indoor shopping malls can be open at 50% of their maximum occupancy. Libraries have the ability to open up at 50% maximum occupancy, but right now the county library system is choosing to stick with their front door service through the rest of 2020. They are still concerned about the risk to patrons, the risk to library personnel if they open up, and the ability to keep everything as clean as you would need to. Because with all of these openings, it's not like you just open your door and you just go in and you don't have to worry about anything. There are some very, very strict state guidelines that need to be followed with regard to sanitizing areas, with regard to space between patrons, with regard to, even in a restaurant, how you handle the silverware, how you handle the menus, things like that. Higher education institutions can actually resume indoor lectures and student gatherings at 25% occupancy. So that's our colleges, universities, or 100 people, whichever is less. And so of course that could have ramifications for DVC. St. Mary's College is the one college where we have people actually living in dormitories. They have been following a very slow, measured approach to reopening and have very good guidelines in place. We're not very concerned about a major outbreak taking place there because they have these very cautious guidelines. I'm sure many of you are seeing across the country as colleges and universities have welcomed students back. We have seen some really, really incredible, surges in these college populations, because even though on campus they're required to wear masks and appropriately social distance, in their apartments, in their dormitories, that's not always the case. And the sad trend we have seen, and our health officer has acknowledged, is that oftentimes in these communities where you have returning college students, about 2 weeks after that surge of college students, you start to see a much wider spread in the community. And so that is a disconcerting trend we're seeing. Again, for Contra Costa, it's not a serious concern, just given where we are with everything else. Now, public schools, or all schools, not just public schools, once we're in the red tier successfully for 2 weeks, have the option to reopen. And again, you still have significant guidelines. And I know our school board in the San Ramon Valley Unified School District has really, really grappled with this of what's the appropriate way. I'm got great respect for their decision making in this. And I think they've got to make what they believe is the best choice for the students in our community. Like the rest of you, I'm excited to have playgrounds open too. It was hard to keep children off of them. And as a grandmother, taking my children through a park saying, no, you can't get on that playground equipment. I don't care if all the other kids are on it, it's illegal. It was not easy. For parents who are concerned, bring your sanitizing wipes in your diaper bag with you, wipe things down if you're concerned. But following those rules, I think, will keep everyone very much safe. Now, as I mentioned, it's still in the community. And so San Ramon, I always love to give you your update. In the last 14 days, you've seen even more cases than you did last time I was here. So you've had 37 new cases in San Ramon. You are up to a total of 352 cases, which comes out to 423 per 100,000 population. In contrast, your neighbor to north in Danville, they've seen 33 cases in the last 2 weeks. They are up to 310 cases, but given their smaller population, rather than your 423 per 100,000, they have 707 per 100,000 cases. Alamo has seen 11 cases in the last 2 weeks, bringing them to 108, but given their even smaller population, they're even higher than Danville at 732 cases per 100,000. Deaths throughout the county, people are still dying, although at a slower rate than we were seeing when we saw that surge through July. So sadly, we've had 200 people die in our community. 110 of those were long-term care facilities. And so as I've been mentioning the last few times I've been here, whereas back in May, 70 to 75% of the deaths we saw were in long-term care facilities. Right now, overall, it just makes up 54%. In the last 2 weeks, the deaths we've seen, 77% of those have been in the community as opposed to a long-term care facility. We continue to be worried, as we talked about extensively 2 weeks ago with Dr. Joseph, about the double surge of flu and COVID, overwhelming hospitals. Could have both at the same time. Symptoms are very similar. Continue to recommend you getting flu shots. We are at some of our county testing sites offering you the opportunity to get a flu shot with your COVID test. San Ramon is one of those sites. So make an appointment to do both. It'd be great to get them both taken care of. Halloween, again, use common sense. Guidance for doing it safely is on the county's website. I think, the idea of decorating the outside of your house, having neighborhoods walk around looking at each other's homes is much safer than knocking on doors and coming in close contact. We do not have an ordinance prohibiting it specifically. We just expect all of you to use really good common sense as you go through it. We continue to see, as I said, the trend for surges in other parts of the county, but overall, we're working very, very hard in those communities to address those. So with that, Bill, I'm going to cede my extra 4 minutes you gave me to Dr. Joseph or to any questions you or anyone in the community may have. We're excited to be in the red tier. We're going to be here for a while, but it does give us many, many more opportunities. And, as we all know, none of us have immunity to it. Even the President of the United States and his wife, Melania. So, be careful out there.
Thank you, Candace. Now, I'm sure there might be some questions at the end of all this. Dr. Joseph, thank you for joining us again. We really appreciate it. And as usual, I give you carte blanche to give us the latest update and information as you see fit. So welcome aboard. And what do you have for us? And are we going to share the screen again?
Yes, sir.
All right. Steve has made you a host, so you can do that.
Okay, let's see if we can make it work there.
Great.
Well, thank you, Mr. Mayor, and it's always a pleasure to be here. Let's. This is what we put on tap for today for the next 15, 20 minutes. And I've put down epidemiology versus individualized medicine. And that was added to my slide deck about 45 minutes ago with the release of the information at 1 a.m. Eastern time last night that the president and the first lady have been reported to be testing positive. So I want to address that. And then we'll talk about some things that I think have been in the news recently, at least the past week or two. A lot of talk about herd immunity, vaccine, and then some new testing. So this is what I added this morning. And this is a concept that I would like all of us to remain aware. The definition of epidemiology is a branch of medical science that looks at all of the factors that determine the presence or absence of disease or disorders. So it's an overview. It's based on statistics. And the things that we look at in the epidemiology of COVID are reported excellently by Supervisor Andersen. We talk about the number of tests, the risk factors for disease, the complications that are broken down by age, by underlying risk factors, by illnesses, by pulmonary disease, the complications as they occur in the younger children versus adults, and the ratios of those. And more statistics discuss hospitalization and what is the likelihood of surviving hospitalization and not. And of course, the death rate associated with COVID by groups. So this is something that we have discussed many times here, but I want to focus on this. Medical epidemiology is not individualized medicine. And I want to caution all of us that whatever we know about COVID statistics does not apply to any single person, including the President of the United States. I'm sure we will hear over the next several days about percentages of complications and percentages of hospitalization as they apply to a single person. Don't do that. You would never want to be treated by your doctor based on a statistic. Medical epidemiology is critically important, but it's important for developing public health policy. It tells us what we want to do as a community, as a county, as a state, as a country, but not how we want to manage a single person. It's not fair to apply those statistics to the likelihood of a single person falling into any group. So what we will hear about Mr. Trump really does not not fit into the medical epidemiology, but rather the important parts are what is said by his doctor, his healthcare team. So just let me caution you that I am expecting, and already have heard on this morning's news, a lot of things that are inappropriate applying statistics to a single person. And that'll be my comments so far, or at least as of today, regarding the new news that was last night. Now, what I had attempted to talk about was two big factors of how we control infectious diseases in the modern era. Now, this is medical control. So there's two big arms. There's treatment and there's prevention. And the treatment is basically for bacterial diseases. We have a lot of antibiotics. And so penicillin for strep throat and multiple drugs for pneumonia. And when a person develops a urinary tract infection, we have a plethora of antibiotics that can be described. So treatment is after a person gets an infection, typically applies to bacterial disease. We have very, very few ways to prevent bacterial disease with immunizations. There are many ways to prevent bacterial disease with what I will call engineering controls. That is non-medical aspects. But I'm focusing today on just the medical side of how we control infectious diseases. So treatment generally applies to bacterial disease. Prevention, on the other hand, applies to viral diseases. And that's because we have very, very few drugs that can effectively cure a viral infection. So the way we control viral diseases is with immunization. Whether the immunization is from a vaccine, whether it's naturally occurring, that's how we prevent infectious diseases. Now, there's many, many ways to prevent infectious diseases that fall into the engineering control aspect, and they're critically important worldwide. Mosquito nets, mosquito repellents, wearing masks, avoiding people, quarantine, isolation. Those are all important to prevent an infectious disease. But when we're talking today about the medical control, and I want to talk about immunity, and that is sort of my segue into what has been on the news a lot, and that is herd immunity. Herd immunity means, and it actually came from the turn of the century from a herd of cattle who were getting brucellosis. And it was discussed of how many cattle need to be immune to brucellosis so that the disease doesn't spread. So an epidemic is an uncontrolled spread of a disease. It's more than what is expected. When there is herd immunity, it doesn't imply that there will be no infections, but it means that there will be no epidemic. All we will see will be the expected amount of infection. Now, with some newer diseases, there was an attempt to change this to community immunity as we apply this to humans. It just didn't stick. So we're now still talking about herd immunity in humans as if all of us are the same as cattle. And as long as we keep the concept correct, we understand it. Looking at that cartoon on the right, if there's about 250 persons in that cartoon. If we look at those who are gold and say that those individuals are immune, that is, they are not susceptible to disease. Those who are green are not immune, and those who are red have the infection. This is the goal of herd immunity. The goal is that, yes, we will have people who are infected. They're the ones who are red, but they won't create an epidemic. Only those few persons who are green are susceptible to infection. So you can see sort of down in the middle of the bottom, those people are close enough that the spread might be by a respiratory disease. So this is our target. Our target is that we want enough people in our community to be immune, not that we want to eliminate or not that we can eliminate infection, but that we can eliminate an epidemic so that we will have only the expected number of new cases. And now the table on the left gives you an idea of where we are. This shows the herd immunity for vaccine preventable infectious diseases. Diphtheria, measles, mumps, rubella, and all of those that are listed. And on the far right of that table, it tells you the threshold for herd immunity. And the most important thing is not the specific number, but that the number is different by disease. So for example, for diphtheria, herd immunity, we need 85% of the people to be immune. But for mumps, we need 75%. And this is based on the infectivity of the virus. So the higher the infectivity, the higher number we need for herd immunity. Now that column that is labeled R0 or R0 tells you that, let's just take the top line. If a person has diphtheria, he or she is likely to spread it to 6 or 7 people. If a person has measles, that's much more contagious, and he or she is likely to spread it to 12 to 18 people. Now let's translate that to our current pandemic. The likelihood of spread from one infected person to another one is lower than all of those. It's about 2 to 3, meaning with no precautions taken, one person with COVID is likely to spread it to 2 or 3 others. And what we are seeing on the right is that the projection then is what we need is about 60% of the people in our community to be immune to create herd immunity. So much lower than most of those viral diseases there. But the point is we are not even close. The point is that the best we see is maybe in small pockets of New York City, which is very population dense. There may be as high as 20% of the people immune. That's not herd immunity. If we say that our target for COVID has now been adjusted down to about 60% from what we know so far, even New York is not close. Those are some other cities around the world. And in our community here, we are at about 3 or 4%, some counties 5% in the Bay Area. So this is just an overview that our target is pretty far away. And we're not going to get there until we get an effective vaccine. So just as a summary, herd immunity is currently our best solution to a new pandemic. We don't have therapy for this virus. There's likely no natural immunity. At least so far, we have not defined any genetic factor that makes an individual naturally immune. They may be out there, but as of today, the answer is no one in the world has natural immunity. We're not close anywhere in the world to having herd immunity, not even in those areas that have the highest number of infections. There still are increasing numbers of infections because the immunity level is far below 60%. The principle of herd immunity is new infections will continue, but they can be slowed until we get herd immunity. There are interventive methods that we've talked about here many times. There's masking, there's social distancing, there's common sense, there's isolation, there's quarantine. All of these will slow down the new infection, but they're not going to go away. And herd immunity in our community, in our country, in the world is very unlikely to occur without a vaccine. Vaccine will be important to make all of us immune so that we can get back to a normal life. And that's just a great segue for me to talk about what's going on in the vaccine world. There certainly has been a lot of news about vaccine, about the timing of release. A lot of different opinions are out there. And let me see if I can just try to bring it into an understandable situation. There are 3 available platforms for making vaccine. There's live virus, and we use that today. We use live virus for measles, mumps, rubella. Some of the flu shots that are available this year use live virus. Now, those live viruses can't cause an infection. They are weakened genetically. but they do stimulate a response to protect us. You don't get measles from a measles shot. You don't get mumps from a mump shot, but those are live viruses. Recombinant proteins are the ones that are most common. So of the 11 flu shots that will be available, or 11 flu products for vaccine that will be available this year, most of them are recombinant proteins. Either proteins that are made synthetically or proteins that are derived from live viruses. And that has always been the workhorse of vaccines, recombinant proteins. What's new and what is the game changer is molecular vaccines. Now, this is why there is so much confusion about how long is it going to take us to make a vaccine, because we have so much experience with live virus vaccines and recombinant proteins. And I'm sure that you've heard the confusing information where one newscaster might say, well, even if we get an effective vaccine, it's going to take 2 years to produce enough to immunize those, even in our country, let alone the world. And others have said, no, we're ramping up and we'll be ready and it won't take that long. And I'm going to try to explain the discrepancy. The comments about a long period of time to produce vaccine are based on number one and number two. They are labor intensive, reagent heavy, and difficult to produce. The molecular vaccines are not. They are fast tracked. Molecular vaccines can produce what you can do in 2 years with a recombinant vaccine, you can do in 2 months with a molecular vaccine. Now, molecular vaccines were first explored with the original SARS epidemic, that's SARS-1, where you create a molecule of DNA or RNA, and you put that in the vaccine, and that is injected. The DNA and RNA then go into a host cell and produce the recombinant protein. So we're using our own body to make the recombinant proteins that creates the immunity rather than trying to do it in a laboratory. And so far, all of the vaccines that are on the phase 3 trial are molecular vaccines, DNA or RNA. Moderna announced the first molecular vaccine with a huge press release about 3 or 4 months ago. And the term was mRNA. It's just one of the molecular products that is out there. The Johnson & Johnson product is a molecular vaccine. So these are extremely encouraging as to where we are going. So an overview of what is out there is here. We have over 150 vaccines in preclinical testing. That means they're in the laboratory trying to design what molecular product will work. And by the way, DNA and RNA are really easy to make in a laboratory. And you make them in huge quantities very quickly. So some of the ones in preclinical testing are molecular, some are recombinant proteins. To my knowledge, no one is using a weakened live coronavirus vaccine right now. So this is mostly recombinant and molecular. There's 28 vaccines in phase 1. And I wanted to go through these because they get confusing and they have been blended a lot during this pandemic. Phase 1, you give a vaccine to a human. This is not animal, this is human. You give them to them and you're looking for the safety of the vaccine, anything that just jumps off the page as making a vaccine different, and what dosing. And vaccines have to be dosed. So do you give a quarter of a cc, a half cc, a whole cc? That's what the phase 1 trials are doing. And after a vaccine is given, you measure the antibody response. From phase 1 information, you develop phase 2. And currently there are 14 vaccines in phase 2 expanded trials. It's similar to phase 1, except the dose is now the same. And this is given to hundreds of persons, and you want to spread this out. So it's going to be given to children, to college-age kids, and to those of advanced age. And looking at the antibody response. So this is still baseline data, and there are 14 of those that are now in phase 2. And there are 11, and this is the most amazing news that we have for all of us. There are 11 in phase 3. Does the doggone vaccine work? And it's given to tens of thousands of people. Moderna started with 15,000 people and reported excellent early results. The Johnson & Johnson or Janssen product is given to 60,000 people. And after phase 3, if phase 3 is successful, in the absence of serious side effects, then you apply for early approval. Now, there are 5 vaccines that have achieved early approval, but none in the United States. Early approval was given to 3 in China and 2 in Russia. And this means that they are open to either the general public or defined populations. We're not there in the United States yet, but it's coming. So this is the process. And after early approval, if it looks good, then there's FDA approval and the vaccine is available to any practitioner. So this is the sequence of events. We have an important part for us to understand is there are 11 in phase 3 efficacy trials, and that's extremely exciting. Now, to put this into the timeline, this was a cartoon that was created by a friend of mine based on the modeling of vaccine development and what we have learned. So this is a 24-hour clock. The goal is if we consider vaccine development as a 12-hour clock, if we consider vaccine development as a 12-hour project, we started at the top where it says start of the pandemic. After we got the first news of the pandemic, after China released the genome or the genetic sequence of the virus, within 2 weeks, we were developing in the NIH a molecular vaccine. That gives you an idea how quickly this moved. You can't do that with recombinant proteins. If you know the genetic structure of a virus, then you can start using those genes to make a vaccine. And it was about 2 weeks after the genetic structure was published. If you would look at this globally, and if our target is to get back up to 12, get to the top, we are at about 7 o'clock. That is with looking at all of the trials, the successful results, and the prediction is that we are about 2/3 of the way there. Now, I'm not going to make a prediction as to the efficacy of the vaccine or the safety of the vaccine, but based on what we know of how vaccines have developed, we could be there sooner than ever before with any vaccine development. I don't think it's going, if you ask me for a prediction, I always try to avoid them, but based on this clock, we're not going to be there before the end of this calendar year. But there's going to, if the vaccines work and if they're safe, we're looking at something in Q1 of 2020. Now I have to emphasize, that's all based as if this model is correct. But it's really based on science, not on politics, not on statistics. It's based on understanding vaccine development. So indeed, it is encouraging news. Until we get there, we have to temporize. And the temporizing is testing and personal protection. So let's talk a little bit about what has happened in the United States with testing. We have now been 8 months since the first test was authorized by the CDC. And the specimen collection has gone from the deep nasopharynx, the one that is not very comfortable, been called a brain biopsy. That was the very first test that was out. Then we went to one where it didn't go so far into the nose. It was a calibrated swab that went about halfway into the nose. Then there was tests developed using just the anterior part of the nose, then saliva testing, and then just gargling. Now, let me analogize this to the testing that we had with HIV disease in the 80s. We developed the very first test in 1985. That was 4 years after the virus hit the United States. So it took 4 years for us to get the first diagnostic test for HIV disease. And you can, in the United States, we developed the first test for this within a month. There are alternatives to HIV disease, including saliva test and oral rinse, and they took 40 years. Well, maybe 35 years. What we have done in 8 months with modern science, with molecular diagnostics, with testing that is now available that wasn't available 3 decades ago, we have changed 35 years into 8 months. Now, this is entitled Temporizing with Testing. So we now, just imagine this. What if there was a quick test, and we talk about pooled specimens, where you can collect specimens from 15 people and run one test. And if that test is negative, all 15 persons are negative. So imagine a school. Imagine a school with 15 kids or a large number of kids coming into school. When you break them up into groups of 15 and you have them gargle a little bit of salt water and spit it out into a container. And you put all 15 of those into one test specimen, and they're all negative. Those 15 kids can go on to class. And imagine how that might apply to the entire country. That is, until we get vaccine, we are working feverishly to develop rapid testing so that we can screen large numbers of people. And they may be large numbers of people going into a school, into a college, into an essential business, into a workforce of any kind. And we've talked about these tremendous problems at the food manufacturing places where people are shoulder to shoulder, and you can't prevent infection and maintain that type of a workflow. But what if all those people were tested every morning when they came to work? The timing for the turnaround of a test, originally when it came out, when we had the deep nasopharyngeal swab that was released by the CDC, was 7 days. And we are now down to many 15-minute tests. And it's extremely exciting. I'm tremendously optimistic about using testing as a way of temporizing until we get the vaccine. But test science, that is the science of making testing equipment, does not mean availability. And I don't want to leave anyone with the information that tomorrow we're going to be screening all the kids. The testing availability, that is how you make a test kit, is a lot harder than making a vaccine. It's very, very difficult. It's time consuming. As I said earlier, vaccines are, with molecular vaccines are easy to make. Test kits are not. So right now, although we have a couple 100 million test kits out there, they are being deployed for specific groups of people. That is those who are symptomatic, first responders, and you can see the list, certainly nursing home residents and staff, areas where there is a great risk for an outbreak. They are not yet available, with a few exceptions, to our community, but it's coming. This is an extremely fast moving science, and rapid test kits will be here before you know it. I can't make a prediction. I can't tell you that next month we'll all be able to get a 15-minute test, but that's the target. And I think that the testing availability will be a game changer until we get a vaccine. I can tell you what's being worked on right now is a saliva test that where it will be a color change. And even a home kit is being evaluated, where you can purchase a kit just like you can for a pregnancy test. This is all under development. It looks like the focus right now for all of us will be rapid testing until we get a vaccine. And so with that concludes what I'm going to say today. Be smart in what you hear and what you do. It certainly is a changing field. Every day there's something new. Mr. Mayor, thank you very much for the time, and thank you, everyone.
Thank you, Dr. Joseph. I sort of wish the whole country could watch your program every week to get the latest update, which would sure cool down the social media stuff that's going on. It's crazy. Steve, you may have some questions. I know Candace and I may have questions for the doctor and vice versa, but I'll open it to the public first.
Sure. I'll start off with a question for Supervisor Andersen. What's the current turnaround for COVID-19 tests at county sites?
Fortunately, we are turning them around in 2 to 4 days. And so encourage you to get tested. Built into that tier metric is if we have more widespread testing, we get sort of a bump up, sort of a credit for that, because we are able then to identify cases quickly. So even if you've been tested before, if you've been out in public, every 30 days you can go to a test. We have also worked closely with our providers over this last month. I mentioned it 2 weeks ago. So the Kaisers, the John Muirs of the world are getting more willing to allow people to get tests even without seeing a doctor first. And so we encourage you to keep getting tested, but our county test sites, they're available and your insurance will be billed. In essence, it's generally no cost. You might get a small bill from your own insurance company or something. So, but the turnaround time, because of the new contracts we entered into, significantly has improved our ability to turn those around, which again, I didn't even go into contact tracing, but we still are reaching right now about 75% of everyone who tests positive. We are able to reach them through our contact tracers. And of course, this is such a critical component that people know they need to self-isolate as soon as they realize that they do in fact have it, because people are still asymptomatic and they may not know they have it and they're spreading it to others.
And as a follow-up question to that, if you get a flu shot vaccine or flu shot at the county-run COVID test site, will insurances be billed?
I believe they will for both. Flu shot, I'm not sure, and I'm happy to check on that if someone wants to email my office. We're calling our flu shots free. They may in fact be actually free, but in most cases, the county bill you. If we bill your insurance company, the insurance generally will pay for it, and most insurance does cover a flu shot as well.
I also want to comment that if you are a Kaiser patient, the new facility in Dublin along 580 has a drive-through flu shot for that. And I just got mine on Wednesday, and it was about 20-minute wait, so it wasn't too bad. They make sure you put your car in park and turn off your engine, because I asked them, so what happens if somebody has a little problem with the shot and kind of faints? But they have that all figured out, so no problems there.
Or bring a designated driver if you're gonna. I have some fainters in my family, and I'd say those people bring a designated driver.
Yes.
That was a concern from my former days working in an ER. I saw people kind of hit the deck on some of these situations. So for Dr. Joseph, are there any drawbacks to molecular DNA, RNA generated vaccines?
None identified yet. And I say that intentionally. We have never given a molecular vaccine to a large group of people. They were designed long ago for SARS when SARS first hit. So the phase 3 trials are critically important for molecular vaccines. That's where one company's giving 15,000, another company's giving 60,000. And the purpose of that is to identify if there are unknown problems. I can tell you that they have all advanced to phase 3 without recognized problems. Stay tuned.
And a follow-up, as opposed to having 1 or 2 vaccinations coming out and trying to mass produce that, if there are 11 different companies producing in phase 3, could there eventually be 11 different vaccination combinations being given to people around the country? So it can happen a lot faster, and you can probably track to see which are more effective?
Yes. An analogy to that is the influenza vaccine that we've been talking about a little bit. I think this year there are 7 different companies making influenza vaccine. The vaccine market is not one-off. It's open to all pharmaceutical companies to develop. Then it gets into dosing. Some may be 1 dose only, some may be 2 dose, but they will all have to meet certain efficacy standards. There's one vaccine comment that is worth noting. Much of the COVID era, including attempted drug therapy like remdesivir, all of the testing is not FDA approved, but rather it's emergency use authorized. The FDA has announced that they will not fast track authorization of vaccines. It's one component of medicine when you start talking about diagnosis, but a completely different safety factor when you talk about giving vaccines. So I would like to reassure everyone that there is going to be intense oversight before a vaccine is available in the United States.
And to be clear, that is good science and not politics, correct?
I don't mix. I don't know anything about politics.
Exactly.
We're going to approach the vaccine from a scientific,
right,
patient first
yes.
Approach, so that safety is important.
Yes. Yes. Okay.
Great. We have a number of questions about can a surgical mask be worn more than once, and can you wash KN95 masks? And I know, Dr. Joseph, you've addressed masks before, but it might be useful for a quick reminder.
Well, all masks are good until they are mechanically defective. A surgical mask can be worn until it's wet. So you can wear the same surgical mask for a whole day if it doesn't get wet. For those who may exhale more moisture than others, it may only last a couple of hours. For smaller people with a shorter amount of tidal volume, that's how much air they breathe in, they may be able to wear it longer. They are a designed polymer of paper and cannot be washed. KN95s is a type of a filter, not a type of a mask. So it depends on the product that is being made. The KN95s that are used in the hospital can be reprocessed, but not with regular soap and water. They require a product of hydrogen peroxide that will disinfect and clean. They are good until you can see a mechanical tear or a problem. The KN95s that are being sold to the general public are so variable that I would hesitate to make a comment and suggest that there probably is no knowledge.
Great. A question for Supervisor Andersen. Is there a scenario where Contra Costa County would move backward into the purple tier?
Yes, there is. Now, unfortunately, if our numbers were to spike in the wrong direction, countywide, not just in disadvantaged communities, we could end up back in the purple tier. And so again, that's where it goes to. We're moving in the right direction right now. Our hospitalizations, we're down in the low 30s again, whereas in July when we saw that surge, we were in the low 100s. Everything is indicating that we're going to be okay. But I'm crossing my fingers, because I was telling you that back in May when we had these timelines for reopening, and we all felt very confident. So my message really is, don't let your guard down. Don't throw a big backyard bash, or worse, an indoor bash in your home. Use common sense. The virus is among us, and we don't want you getting sick. And yes, some of you will have zero symptoms. Some of you will not be impacted at all, but others really will. And that's what we do not want to see. We do not want to see a surge in hospitalizations. We don't want to see our hospitals overwhelmed so that people unnecessarily die, because we do have really good treatments. So it really is, it's looking out for one another. Wearing a mask is the best thing you can do for your fellow man and yourself.
And a follow-up, Candace, what are the county rules on wearing a mask outdoors?
We still have a mask ordinance in place. And so again, if you're going to be within 6 feet of someone, you should have a mask on. If you're just walking outdoors by yourself and you're not coming near, you don't anticipate close contact, keep a mask in your pocket that you could flip on if you're going to see people. But when you are outdoors and when you are entering stores, when you're entering buildings where you're going to be around other people, even in a work site where you can't be 6 feet apart, you need to have a mask on.
And Dr. Joseph, a follow-up to reassure people that if you're 10 feet or so apart outdoors, how safe that is without a mask.
Well, science supports that there's minimal risk beyond 6 feet without a mask. The air exchange of the outdoor air is so rapid that it requires an imagination to how one person could affect another one greater than 6 feet away outside. But with a caveat, even though the science supports that, and that's what's being published in the research, it is very important to follow the order of the county health officer. And some counties may be more strict than others. Some may require more than 6 feet. I would never want to go against what a county health officer says is required, because it takes in so much more than science. You know, the county health orders are not based on reviewing medical literature. They're based on understanding medical literature and the community and how the two have to be merged. So please follow the county health orders, and I'm happy to discuss the science that goes into that order.
Well, you noticed I asked her the question first, and then your information second. Somebody in the audience had raised their hand. Steve, I think you'd like to have them send the comments to you.
Yep. At info@sanramon.ca.gov. If we can't get to it, because I think we have time for one more question, we'll be sure to answer their question or save it for the next Mayor's Breakfast.
Well, I have a question of Supervisor Andersen.
Sure.
and I'm not trying to put you on the spot with this, but you casually mentioned that individuals can go to John Muir and be tested without a doctor's order.
Well, no, I said Kaiser is working toward that. We're trying to work with John Muir to get them to do it as well. So I apologize. I do not believe, I've not had confirmation that John Muir is. We've been working with them with our other health partners. I know Kaiser is now allowing that. So I apologize. I may have misspoke on that.
Well, let me tell you my understanding of this and how we have worked around it. In California, a laboratory test it requires a doctor's order or a doctor's designee. That's not true in all states. In Arizona, an individual can order their own blood tests. But in California, it's still that way. My understanding is that the county sites bypassed that by saying, this is an order from Dr. Farnetano. You can go to a county site and get tested without having a specific order of your private doctor. And that's fantastic. I favor testing, and I would love to see us find all sites being able to provide testing without a specific doctor's order. Now, there's complications with that. I recognize them. What do you do with the results? But if we can do it at a county site, I am a proponent of doing it at all sites, making testing widely available, like we have for HIV disease. You know.
Well, and that's a good point. I think that it's something I'm going to bring back to Chris, to Dr. Farnetano, saying, could our health order be crafted in such a way that says you do not need to have a doctor's order to get a COVID test, which would then open it up. I understood it was more barriers from medical providers. Again, these tests, they're not free. They do cost money, and they've been at various times in limited supply. And I can understand why medical providers are concerned that they want to save those tests for those who truly need it, and not just for anyone. But that's something I think is worthy of a discussion, or if it's state law. I've got a great state delegation with Senator Glazer and Assembly Member Rebecca Bauer-Kagan, who I think would be very anxious to change state law to allow that, if in fact that's one of the barriers to testing.
Well, I believe that would be a move forward. They certainly have for HIV disease. Anyone can be tested for HIV disease anonymously or by giving their name. The results go back to that individual. Reporting, I assume that you've already handled all the reporting problems because you're doing this at county sites without a specific order. And
we have a health order that mandates anyone who administers a test to report it to the county. And so we have handled that aspect early on back in March and April, because we very much needed those statistics wherever they were being gathered. So I'll have to talk to Chris about that and find out if there's something more we need to be doing to facilitate it. I think, with our hospitals, medical professionals, we work very, very closely with them and with the hospital council. And I think what we're going to see too with the vaccine, which my understanding is it has to be refrigerated. And so it's going to be, as we work on rolling out the vaccines, we're going to need to be working closely with our hospitals because they have some of the best and largest refrigeration capacity to administer the vaccine. So it's a great partnership we have and we'll continue to have.
Thank you.
Steve, we have time for a really good question, or are we all wrapped up?
We have time for one more question. It's the person who raised their hand in the chat, asking if, and I don't know if Supervisor Andersen has this information offhand, if there are any current COVID hospitalizations at San Ramon Regional. I know, oh, go ahead.
No, I was going to say, you can go onto the state's data map. And if you just Google COVID hospitalization, state of California, there is a data map. It will show you a scatter graph that shows you a map of the county and where COVID patients are hospitalized. And you can guess where they are. Because of HIPAA, we do not detail how many individuals are at each hospital. To date in San Ramon, you've only lost 2 individuals to death at any given time. There have been people hospitalized here, but go to the state's website and you can see that information right there of where those patients are hospitalized.
And just because they're hospitalized in a particular hospital does not mean they come from that community.
Not at all, no. And early on, we were seeing many of our patients showing up in Alameda hospitals, county residents, because out in West County, that's where they receive their hospital care. And as we saw significant surges down in the South State, as I mentioned early on, we were getting some of those patients transferred to our local hospitals. And then of course, when San Quentin had the outbreak, we didn't get those patients, but San Francisco, Marin were overwhelmed with some of those patients.
Exactly.
So.
What we're going to be doing going forward is we're going to meet again either 2 weeks or 3 weeks, subject to a week or more from now if there is a compelling reason to get together. I would look to Dr. Joseph if there was a compelling reason, if we should meet in 2 weeks or wait 3, or if news is breaking, because I want to make sure that these gatherings are compelling and informational. The next time we do get together will be the last Mayor's Breakfast we have prior to Halloween. So Candace, getting an update on the latest rules governing Halloween behavior would be helpful. And Dr. Joseph might have some thoughts about if indeed there are behaviors allowed or activities, how to make sure we can keep children and families safe. Is that a fair ask?
It is, and I would invite people to go to the county's health website, or coronavirus.tchealth.org, because we already have some really good suggestions for how to celebrate Halloween without being in close contact with other individuals.
Yes. And Dr. Joseph, is that a fair ask of you?
Yes, sir.
I'm not overstating the fact there are a lot of residents who look to you for good, solid advice, and we appreciate the time you spend every week getting ready for this. And so thank you very much. And we'll be posting along with all your other slide presentations on our website so people can visit it later on. And again, thank you very much, sir.
Thank you for the comments.
Candace, thank you for being here and being here every week for us. Thank you. Steve, for organizing this event for us and quarterbacking the questions, and to the residents who are taking the time to, hopefully we can all stay better informed. Have a safe weekend. And we'll see you in either 2 or 3 weeks. Thank you.